Welcome to MedHeads, the weekly show that brings a biopsychosocial focus to issues of the day, along with special guests who will showcase their expertise and enthusiasm about their field of practice. Your host, Dr. Ferghal Armstrong.
Hello everyone, my name is Dr. Ferghal Armstrong and welcome to this episode of MedHeads. We're very lucky to have with us Maree Eisma. Hello Maree, how are you?
I'm really well, how are you?
I'm pretty good. So I thought we'd talk today about school refusal.
Yes.
And you know, you've got a lot of expertise in this area of practice. So what is school refusal?
So generally we're seeing school refusal as being connected with anxiety, usually resulting in an avoidance of students wanting to attend school for a whole range of reasons.
Yeah. So it's that lack of attendance at school, but of course it doesn't just happen overnight. It's quite common to have a progression from school reluctance through to school refusal. So what does school reluctance look like? What's the progression look like?
Yeah, so school reluctance is where we usually start seeing students complaining of belly aches, butterflies in the tummy. You might start seeing students requesting to go to the sick bay more than, to increase in frequency of, needing to get out of class because of having nausea or all these other sort of often somatic complaints. And we often start to then see where, there's just a lack of even, commenting about enjoying school. Everything feels like it's a drag. And usually in retrospect, we'll find that the school reluctance period has gone on and there's been comments like that to, the students been voicing these just lack of motivation and a whole these other symptoms. And then they realise that, all of a sudden it becomes school, for school reluctance, and then they just basically don't go and they completely, it's become school refusal.
Yeah. I can remember once telling a parent, well, just take your child to school. I could not comprehend that a child could have such power over parents. And I can also remember telling parents when they came to me and said, oh, my child won't take the antibiotics that you prescribed them. I said, well, just make them take it. It's taken me a long time, unfortunately, for the sake of my patients, it's taken me a long time to realize that you cannot really make kids attend school. You can encourage them. You can provide reward. You can provide punishments. But you can't actually make your kids attend school.
You're right. You can't actually, just like we can't pin someone down and make them have medications, their antibiotics, we can't drag kids out of the school and literally drag them across the asphalt and literally throw them in the school door. You can't do it.
So it's all about understanding the psychology of the situation, really. And I say the psychology of the situation because we have to understand the context. And I know you've got views on context, but for me, it's all about primary gain, secondary gain, and sometimes even tertiary gain. So, if we talk a little bit about primary gain and the sick role, sometimes children like the sick role because they get attention. They get that positive validation of being the center of attention and enjoying the benefits of it. Tell us a little bit about that.
Yeah, so I see this in a fair bit of my work, perhaps where a child or a student, has got very, very busy caregivers or parents who might be doing, long hours. And then all of a sudden the student gets sick. And for the first time in perhaps a long time, there's mum or dad present or the caregiver present. And it can feel like, oh, I'm seen. I'm actually witnessed by the eyes of the parent. And for a child who may have otherwise felt ignored or, other things taking priority, it's understandable that a child might actually really appreciate that. And there's an example of where that can become an unintended reinforcer because for the first time the child's getting the attention and connection with parents that the child may not ordinarily be getting.
Yeah. And then we have the concept of secondary gain. So the child assumes a sick role for a secondary benefit. So, for instance, it could be to avoid a stress, which could include bullying. So, perfectly reasonable, the desire to avoid a stress. So it could be the desire to avoid bullying. It could be the desire to avoid a test.
Yes.
Or it could be the desire to avoid merely overstimulation. I mean, there's a lot to unpack in that point, isn't there?
And that's actually quite right. There's the avoidance of not wanting to look unintelligent. So for some students, if there's going to be, the NAPLAN is a classic. Students not wanting to turn up because they have to, undergo tests or performance or public speaking or something like that. There's many examples. And for some students, it's overstimulation. They don't know what to do with the too much noise coming in from all directions. They don't have the coping skills to cope with it.
Yeah. And then sometimes we have, quite rare, I suppose, but there is the possibility of what I would call tertiary gain when for some reason there's actually some kind of gain in the part of a third party, and that third party could be the caregiver.
Yes.
Have you ever seen that?
Oh, yes, definitely. I've seen this play out where, say, parents might not be together, and the child, it can play a part for the parent to perhaps get a bit of extra time, get some brownie points with the child. Sometimes it can be, another way of getting at the other parent. Sometimes we see the undermining between parents. One person has a concerted effort about making sure the child goes to school. But if there's a lot of parental conflict, then the other parent might undermine. Other examples could be, where in, some extreme cases where the parent derives a benefit in the child staying home to look after them and attend to their psychological supports.
Yes. So there are multi-levels and multi-tiers of the psychological context that one needs to understand when one is approaching this problem of school refusal. And I think going back to primary gain, I think it's really important to tease out what we mean when we talk about somatization. Because somatization is really the core of primary gain. Now, can you explain to us what that means in your context?
Yeah, so the somatization is that, for a child, when they start getting the belly upset, or they're racing to the bathroom, or they're feeling like they're going to be sick, it is very real for them. And I've often, when I'm trying to do some education with parents and even with teachers, I will give them the example of imagine if you're at a park and a ferocious dog comes bolting at you off lead, and the sense of anxiety and surging of all of those stress chemicals running through your body. Well, we kind of understand that might happen when a dog comes charging at somebody and we don't know, especially if its teeth are showing. But yet for a student or a child at school, that's exactly what the level of their distress can feel like. So well-meaning people can say, oh, look, you're letting your thoughts run away from you. It's not really that bad. But yet if that's the physical sensation that is occurring for a student or a child, it's real for them.
Yeah. And for me, the issue about somatization, and I suppose in particular what we call somatic symptom disorder, that's a really, really difficult diagnostic dilemma to tease out, because, you see a kid with bellyache. They've missed school, and then the mother the granny usually drags them to the surgery, and, you fix my child, he's got bellyache. And you're looking at the child and you're feeling the belly and you think, is it or isn't it? I once looked after a child. She was 12 years old and she had recurrent abdominal pain, and we all thought it was appendix, and we kept sending her in, query appendix, query appendix, query appendix. And eventually, the surgeon said, stop sending her in. There's nothing wrong with her appendix. We're not taking it out. And then we started going down the counseling route, and the mother and the child were looking at us as we were trying to explore, anxiety issues and psychology issues, and they were looking at us as if we were mad. But the mother said, "Look, just play along," because even the mother acknowledged that there had been frequent recurrent abdominal pain episodes, but with no diagnosis. So I'll never forget, I talked to this child about visualization, talking about, the happy place that she was in. And the very next day I got a report back from the test that we had just arranged, because it was a new fancy test. And that test proved that she had chronic rumbling appendicitis. 2 days later, she had it out and never saw me again. So
Exactly.
it's from a clinician's point of view, it's very difficult to tease out what's going on. Sometimes it's important to make that distinction between organic pathology and somatization disorder.
Very much so.
But it doesn't happen overnight, and it doesn't necessarily figure first and foremost on minds. But the risks of not dealing with somatoform disorder include over-investigation of pathology, and also something like the higher false negative rate of appendectomies. So when you take an appendix out, you're assuming it's inflamed, but when you look at it in the microscope, it's not inflamed.
Yes.
So that the rate of negative appendicitis for people who've undergone the surgery to actually remove the appendix is very high in somatoform disorder.
Yeah.
So what do you think about that diagnostic dilemma?
Well, I mean, and yeah, it's one of those ones that, as certainly when I work in schools, I certainly don't want to be making any I'm straight off hand it back to the doctors, because it could be a false, and I'd hate to sit there and think somebody's appendix actually does rupture all the while. But I think it's important to kind of really get a really good history of when do these symptoms start? Was anything else going on? And I think when we really do a really good, thorough understanding, and obviously collateral information, not always relying on the student. I mean, obviously their contribution's important, but sometimes when we even get back and start speaking to teachers at the school, or speaking to the wellbeing team at school, we start to realise that the picture's a bit more than just all of a sudden onset of problems. There's usually been a lead up, e.g. bullying or something else has happened.
Yeah. And another category of student that I worry about are those who are labeled as the troublemakers, because they may present as needing or as having special needs. So, for instance, people with central auditory processing disorders, or people with ADHD, or people with what used to be known as the yuppie flu, but chronic fatigue syndrome. This happens in teenage years. All of these diagnoses are valid diagnoses, and yet, it's sometimes, and I have seen this, that sometimes children can be punished for that suffering, and their suffering is not actually validated by if not their teachers, then possibly also by their parents, and that can create friction. So when you're having to say to a school, look, this child has got special needs, do something about it, accommodate this need, that can be an issue.
Yeah, for sure. And I mean, like even at the Monash Hospital, like there's a specific team that actually works educating people in the community, teachers and families and doctors, like even for students who have chronic fatigue and things like that. So, there is education out there, because physical illness can be a very good reason why students do end up not attending school. I know students that have had, untreated seizures, and they've become, I mean, I used to have chronic asthma as a child, and there was a really big thing about not going to school because people, I'm happy to share this, because the medication back at that time used to have to be administered into a syringe to get the right dose combined. People would like, oh no, she's having to be injected. There's a lot of medical reasons why people don't go to school, and it's very legitimate.
Yeah. And then, of course, we know that there's another group of conditions where we know that stress does play a role in triggering that condition, like a classic being migraine. We know that, people get migraines just thinking about a potential forthcoming stress. And, migraine is by no means a factitious or somatoform disorder. It's a very real disorder.
Yes.
So I suppose, when we're talking about, school refusal, we're talking about, all of the gains, and we're discussing, what somatoform disorders are, and then we're talking about disorders that actually do cause, or cause functional impairment to the point where there is no possibility of school attendance. So there's a huge range of issues to consider. But in terms of your expertise as a psychologist, what do you do? I'm a GP, and I've decided that this kid may have a school refusal problem. My heart, goes out to the parents, and then my next thought is, well, where to next? And thankfully, you're here.
Okay, so the sort of things that we're often looking for is tracking the story in regards to when did it all start to become when did we start to see the reluctance become refusal? So if a student, we know that the consequences of not getting on top of this is that with continual school refusal, we've got the challenges of the student falling behind academically. They can't keep up with their peers. If they were worried about attending school because of, if they were worried about sitting tests or having to read in class and feeling that they're going to be judged negatively or anything like that, then the more that the student then avoids school, the more some of those concerns end up intensifying, because then the student's at home creating lots of stories that may or may not happen in their mind. There's no what we call exposure. And the other thing that can happen is the fracturing of the social connections. So the students can then become very fearful that they're forgotten by their peers, that their peer networks have all made these new cliques, and then all of a sudden they're on the outer. So the more they're at home, the less exposure getting, and the more that they're going to be able to, create more and more what ifs, which we know actually fuel the anxiety.
So those are the dangers really of not treating, but actually what does treatment involve? What do you actually do? Apart from understanding the context, what's the therapeutic principle in this?
Yeah, so
is it graded exposure?
It is, yeah. So we for a student who's actually fearful of going to school, as far as they're concerned, they're in their danger zone. They've actually hit their danger zone just merely at the prospect of going to school. And what we need to do is work out to get into what we refer to as the stretch zone. And the stretch is where we take somebody out of their zone of comfort in ways that are likely to have some sort of success. So ironically, what we know tends to work is that we don't encourage students to start their first day back on a Monday. For some reason, the idea or the prospect of starting at that day, the week feels too long. So we might look at, first of all, establishing a sleep routine that's back to normal. One of the things that's a big trigger is when students start going to sleep late and then sleeping in very late in the morning, and then they've missed their, they've missed their boat to get to school. So we try to make sure that their sleep pattern is back to some sort of, normality. And then we might work out, what does the student need? Do they need to walk around the school in, like you said, in a graded way? Do we let them walk around the school ground on a day where students may not be there? Do we bring them in and just let them sit in a certain space? Do we get them in on the subjects that they actually like, where there is no social, maybe where there's no academic, stressors, where they're not going to be feeling that they're less than? So there's a whole lot of things that we look at so that we can try to get some wins on the page for students.
Yeah, and it's not just about getting the parents and the child and the GP and the therapist in that space. The school and the staff at the school also have to play a role in it, don't they?
That's exactly. We have to make sure that everyone is on the same page, and that there's no undermining or unintentionally undermining any of the significant people involved in the treating process.
All right. Well, Maree, thank you so much for your expertise. I look forward to speaking to you again very soon, but bye for now. Thank you.
Thank you.
My name's Dr. Ferghal Armstrong. Thanks for watching MedHeads, and we'll see you next time.